Jerusalema ikhaya lami, ilondoloze uhambe nami, zungangishilana. Jerusalema ikhaya lami, ilondoloze uhambe nami, zungangishilana. Dawo yami ayikholana, buso wami awukholana. Ilondoloze zuhambe nami, dawo yami ayikholana, buso wami awukholana. Ilondoloze
Hi, Sarah.
Hi, Sneha.
Namaste to everyone. Welcome to day 2 of the YILAGA International Conference.
We are delighted to be your hosts for today. Let me introduce us. I'm an endodontist working as professor at St. Gregorius Dental College, Kerala, and my co-host Sneha is a business analysis specialist and a musician. So Sneha, what's been planned for everyone today? I'm excited to know.
Well, Sarah, today we will be exploring the individual and the environment. We will hear from eminent speakers and witness panel discussions throwing light on various topics that influence and enhance the graceful aging processes. It's going to be a power-packed day.
Sounds interesting. The quality of a leader is reflected in the standards they set for themselves. Here is a lady who is using her education, profession, and life experiences into developing a wholesome curriculum for individuals to lead a life of healthy living and graceful aging. Please welcome the founder and president of YILAGA, Dr. Sal Chaco, to deliver the welcome address.
Welcome to YILAGA's International Conference Day 2. Today we have panel sessions on topics relevant to geriatric care management, which is YILAGA's core curriculum. These are complementary topics to the central notion of providing care to the elderly. These topics combined with the YILAGA's curriculum result in a complete platform to improve quality of life for elder and their caregivers. Our panelists are specialists and experts in their areas of knowledge from around the world. Today we have mental health specialists, chronic disease self-management program designers, technologists, urban planners, and alternative holistic medical therapists. We thank them for finding the time to share their knowledge with us. Welcome to you all.
Thank you, Dr. Sal Chaco. Teachers and trainers have been playing an important role throughout our lives, enabling us in every way. We have amongst us Mr. Reinald Thomas, our first special guest for today. Mr. Reinald Thomas is a higher secondary school teacher since 2011. His credentials are MA in Psychology, MPhil in Psychology, MPhil and an ME in Education. He is a mentor who has been impacting the lives of all his students.
Our second guest of honor is Ms. Rinku Bhattacharya, who is an Associate Director of Learning Support. She is a certified educational therapist and runs a learning difference program for neurodiverse individuals in California. She is an executive function coach and an academic mentor who embraces neurodiversity by systematically looking at interventions and providing multisensory approaches based on specific learning styles. She believes in giving these individuals her unwavering support and motivate them to be their best.
We welcome you, Mr. Reinald Thomas and Ms. Rinku Bhattacharya. At ILAGA, we believe that love and happiness are the goals to healthy living and graceful aging. Music, dance, drama, yoga, gardening are only some of the tools that we use to achieve this. Next, we have a musical indulgence sung by Mr. Kishore Verma, presenting Vande Mataram.
Vande Mataram, Vande Mataram, Sujala Sufala Malayaj Shitala Sasya Shyamala Mataram Vande Mataram. Shubhrajyotsna Pulakitayamini Pullakusumita Dhrumadala Shopini Shubhrajyotsna Pulakitayamini Pullakusumita Dhrumadala Shopini Subhashini Sumadhura Bhashini Sukhadam Varadam Mataram Vande Mataram, Vande Mataram, Vande Mataram.
Globally, mental health has a crucial impact on all ages. Coming up next, we have a panel of 4 who will be discussing the global perspective of mental health. Dr. Matthew Verghese, who will be chairing this panel, was associated with NIMHANS for more than 20 years in various important positions. He developed the family intervention programs for schizophrenia and dementia. He retired as a senior professor of psychiatry at NIMHANS in 2021. Currently, he is holding the post of adjunct professor in St. John's Medical College, Bangalore, India. Joining him as his panel members are Dr. Somnath Chatterjee. He is a psychiatrist responsible for SAGE, which is WHO's study on global aging and adult health. He has worked with WHO for over 20 years and has held several important positions. He has contributed to several crucial WHO flagship reports, including World Report on Aging and Health in 2015. Dr. Mala Kapoor Shankar Das is a sociologist, gerontologist, health social scientist, international consultant, and retired senior faculty at the University of Delhi. Dr. Josephine Antoniette is a PhD, a research fellow at NARI in the Division of Social Gerontology and an affiliate at Monash University, Division of Global and World Women's Health. She was a part of a comprehensive scoping review about older people's mental health and well-being in Australia, a study commissioned by the Australian National Mental Health Commission. Her current work is focused on culture, aging, and dementia, mental health non-clinical. Please join me in welcoming Dr. Matthew Verghese, Dr. Somnath Chatterjee, Dr. Mala Kapoor Shankardas, and Dr. Josephine Antoniette.
Good evening, everybody in India, and late night in Australia. Thanks, Joe, for joining in. So it's very late for you. And good morning in other parts of the world. I think it's afternoon for Somnath. First of all, I'd like to thank YILAGA and Dr. Sally Chacko for having us do this panel to talk about global perspectives on mental health and aging. And I would also like to thank my panelists, Somnath, Mala, and Joe, who have been introduced and who very readily agreed to join in this panel discussion. As you have heard, all three of them are very distinguished people researching these aspects of mental health, especially with regard to the issue of aging. All of us know that mental health is a very important component of human life. And I think that has been exemplified in the last 2 years with the COVID pandemic. And we all know, we've read, we've seen, we've experienced how older people in our own families have been affected, have experienced this problem. And maybe one of the flip sides or plus points in this whole pandemic in the last 2.5 years is that mental health is now finally being given the prominence that we mental health professionals think it should have deserved way, way back. Because the old adage, no health without mental health, is something that is so very prominent at this point of time. Many countries have had projects on aging, and Somnath is very familiar with them because he was responsible for one of the first reports of the WHO on aging and health. We ourselves have in our country the longitudinal aging study of India, which has thrown up a lot of issues, which I will bring in the discussion in the next few minutes. But I will first ask each of my panelists to give a brief talk about their perspectives about global issues with regard to aging and mental health. So I'll start with Somnath and go over to Mala and then on to Joe. And then we'll come back again and do some question and answers around the table. Somnath, over to you.
Thanks very much, Matthew, and thanks, Sally, for inviting me to this meeting. I'll start where actually Sneha began, that this is a session about the individual and the environment, right? Now, why does that matter? Because we define healthy aging as the ability of older adults to be able to do the things they value in their real world environment, right? And this is essentially the outcome of an interaction between an individual's health and the environment they live in. What I plan to do in the next 5 minutes is to just give you a quick idea of the kind of work that I personally have been engaged in and on behalf of the World Health Organization, give you some highlights of what I think are our main findings, which highlight the importance of mental health in the context of this panel, and what can we do about this, and why it matters. Besides what Matthew already highlighted, that, you know, in the course of the COVID pandemic, we have seen why mental health has become a very prominent issue. So our studies on global aging and adult health is essentially a set of studies, a longitudinal cohort of about 45,000 people in 6 countries, including in India, who we've been following for the last 15 years. And much of the insights that I'm going to talk about are essentially gained from that study, besides a range of other studies that we have been sort of doing in Europe and elsewhere. So to emphasize, as you probably all of you are aware, I mean, I don't need to belabor this point with this audience that aging is an issue not really of the high income countries. In fact, already a majority of the older adults live in low and middle income countries. And clearly, the health systems in low and middle income countries are just not prepared for this. They haven't been prepared, they're not prepared now, and they won't be prepared for the future. It's already too late, but I hope that health systems around the world will respond to this at least now. Because at least a fifth of older adults suffer from what we call multimorbidity, which means they have multiple illnesses. So it's not a single illness. And often there is a comorbidity between physical and mental illnesses. Now, what that really means is the services that the health system needs to provide for older adults essentially needs to be a model where you provide integrated, people-centered health services. Because, as I said, not only do physical and mental disorders coexist in older adults, but it is actually the coexistence of this that actually produces the worst impact on health. In other words, if a person has diabetes and then has depression in addition, it has a much, much more severe impact on that person's health than either of those two conditions alone. Now, that clearly has implications because what often tends to happen when an older adult visits his healthcare provider, the person often detects the physical illness and perhaps manages the physical illness, but fails to detect the accompanying mental illness and fails to intervene, which means you never really provide that person with the services that person needs. And of course, as people grow older with age, these comorbidities, as well as the impact of the mental health condition, actually worsens in older age, right? So we had often thought, and it was actually a myth, if you look at the literature about 2 decades ago, that mental illnesses or mental disorders are actually a problem of the young. But we clearly demonstrate that many of these mental health conditions actually worsen with older age. And the impact of those conditions actually worsens as people grow older. And it's not just about mental disorders, right? Because this panel is also supposed to be about mental health. So mental health, of course, is not merely the absence of mental disorders, but what we refer to as subjective well-being. So what we also show is that unlike in the West, in most high-income economies, what you find is typically subjective well-being follows a U-shaped pattern, right? So when people are beginning to work or they are younger, their subjective well-being is at its peak. When they have a whole bunch of responsibilities at home, the well-being actually drops during midlife, and then it picks up again in older ages. But in low resource settings, that is not the case. Actually, subjective well-being tends to decline continuously over the course of the lifespan. And in addition to the decline in subjective well-being, there is an increase in loneliness. And of course, the COVID pandemic has highlighted, what has been now called the epidemic of loneliness. And once again, this is not just a problem. We had believed that, in our kind of settings, we had large families, we had joint families, so people wouldn't feel lonely and they had a big social network. But that's clearly changing. Right? Single person families, even in countries like India, is on a dramatic rise. And this is not just in urban settings, but also in the rural part of the country as well, which means people are increasingly becoming lonely. Their social connectedness, their social networks are on the decline. Now, why does this matter? Because subjective well being is one of the strongest predictors of future mortality, right? And there are things that can be done to improve the quality of a person's life in terms of their subjective well-being by changing the time use pattern of older adults. And that's an eminently doable intervention which really doesn't cost much because we actually know the kind of activities that people engage in which is associated with negative emotions and misery. Finally, what I want to say is that, of course, all this doesn't happen equally in every single individual, right? So there are very clear inequalities that exist in terms of education, in terms of income status, in terms of rural urban distributions. Often, all these health outcomes, all the well-being outcomes are worse amongst the poor, worse amongst the people who are less educated, and worse in rural areas. So, and finally, we are now in a phase where we can actually predict the way people will age. So if you start at a certain point in time, as I said, everybody doesn't age the same way. But it's possible for us now to actually predict the kind of groups the person will belong to. And that is the time to intervene. So it's the preventive and promotive interventions that will actually alter the trajectory of the way people age. And as I said, the time to act is now. And if we don't do it now, I think it'll already be too late. Thanks very much, Matthew.
Thanks. I had some issues, so I just shift to the place. For issue, because I think it would come out turn to about the issues of gender with regard to all these issues, because I think the issue that Somnath mentioned
Thank you. Before I share my preliminary thoughts on the topic of global perspective on mental health and aging, and stress on the need to consider gender aspects in our discourse, I want to, at the outset, state I'm pleased at having the opportunity to be a panelist for this important topic and glad to be amidst experts whose work I value. I now come straight to the issue of the need to pay attention to gender dimensions with regard to mental health and aging. It is important for us to realize that as few studies since some time are also indicating that the life course timing in the onset, type, and expression of mental illnesses follows sex and gender specific patterning. This is seen in a number of mental health disorders, such as Alzheimer's disease, depression, anxiety, schizophrenia, and even in the case of substance abuse. Understanding the gender specificity of mental health issues is pertinent as it reflects how the care provisions in societies are channelized with implications for the affected individual, for societal responses in developing care services, for assessing the social and economic burden of care at the micro and macro level, for analyzing the strain on families, for the kind of responses that are generated in policies, and what kind of costs it entails to the society as a whole. If we look at the global projections being made for mental illnesses, the number of those with dementia will double in the next 2 decades, and the proportion of women is being estimated to be higher because of feminization of aging taking place in almost all countries. In addition, this demographic reality of aging societies is also being projected to be the cause of late life depressive disorders, with higher proportions of women affected. Further, as prevalent studies world over are indicating, mental health issues are leading cause of disability in later years, with higher proportion of older women and specifically widows being affected, and who in most societies belong to the most vulnerable segment of the population. This dimension becomes critically pivotal in our concern for developing services having appropriate care mechanisms in societies. It also pertinently places the need to have adequate provisions for long-term care facilities, both at the community and institutional level from a gender perspective. We must reflect on why looking at things from a gender lens is also imperative. It is because world over, studies are indicating that mental health and well-being of older men and women are influenced by varying personal characteristics, cultural factors, family constructs, and national policies and resources where gender considerations are kept to the minimum. And thus we see gaps in met and unmet needs. Therefore, the point I want to bring to attention to in this symposium is that in understanding issues related to aging and mental health from a global perspective, gender dimensions should not be overlooked or ignored. And when we discuss the status of aging and mental health, including its prevalence, caregiving provisions, policies and services to address the concerns, no matter in whichever country it may be, in any region of the world, we must pay attention to the needs and appropriateness of our responses as these cater to older men and women, along with paying attention to other heterogeneous characteristics of the aging populations. I will stop here, but would like to come again to highlight how we should develop effective approaches to address geriatric mental health issues for women, specifically whose needs are often ignored. Thank you.
Thanks, Mala. Thanks for emphasizing the issue of being a woman and the important issue of gender. And we will indeed come back to what needs to be done to address this imbalance. We'll now go to Josephine. And Josephine, I'm sure will talk about some issues of healthcare utilization and also ageism. But if she doesn't, I will ask her about this later. Jo, please.
Okay. Thank you. And thank you. I want to just chime in with Mila, and thank you very much for inviting me onto this panel. I'm very excited to see you all and be able to sort of share my thoughts with you. So as mentioned, I have recently been part of a large scoping study to understand what mental health means to older Australians. And as part of that study, we sort of tried to identify what key issues stood out and what's important for them, both in terms of prevention of mental health issues and also what needs to be done or what people felt needs to be done to better support people who actually live with mental illnesses. And as part of that activity, the study was a very quick but very intense study. So we did a large systematic review of interventions. We did a policy review of all Australian mental health policies as far as we could find. And we interviewed and ran focus groups with people who have a lived experience of mental illness, older people, carers, policymakers and service providers across Australia, we tried to sample both cultural diversity, different sexualities, gender, all those sort of things we tried to incorporate. And what really stood out to me, because I've looked at a lot of the data, and particularly stories from older people, whether or not they had mental health problems, was the issue that anyone who has more than 65 candles in their birthday cake face in Australia, and I'm sure also overseas, is ageism. And as part of that, ageism came across as a cross-cutting issue that really impacted on older person's mental health, and in ways that were both on a personal level, where it impacted their ability to work. And that what you were saying, Sarah, was, we want to support people to do the things that they value in life. However, a lot of the older people we spoke to were not able to continue doing the things they valued in life, which was work, which was engaging in the activities that they wanted to engage with. And for many, and also Marla, there's just so many intersectionalities here with the gender issues as well. Women often were left behind and faced more ageism in the workplace. Even though they wanted to continue working, they were highly educated, they couldn't. And so that really caused them a lot of psychological distress. The other thing that we found as part of our review was that there's structural ageism, where older people are not meaningfully included in policies around mental health. They're mentioned, but they're just stuck into a bucket of vulnerable communities. Anyone over 65, but as you mentioned, Samat, each person ages differently. You can't say, okay, well, I'm going to age just like my brother will, or like my neighbor will. We all have different abilities. We face different challenges in life, but yet older people in policies are often just mentioned as older people. So that was problematic. They weren't meaningfully included. Funding, similarly, not receiving the same amount of funding as, for example, younger people. And while we live in Australia, we have good mental health services. Many people, including providers, said it was much harder for older people to engage with mental health services, partly because there's a lot of stigma around mental health, still, especially in the older generation, but also partly because services just weren't set up for it. They weren't set up for dealing with the issues that older people face. It's like, have a cup of tea, you'll be all right. It's okay, you're just getting older. Everybody has a little bit of depression, a little bit of this and that. So I think ageism is really one of the issues that we need to consider if we want to meaningfully actually ensure older people's mental health and well-being. And as you say, actually prevent distress and help people live meaningful lives as long as possible. I have many friends who are, over 65, and they are much more productive than I am. So really let people live the lives that they want and value and contribute to society in ways they would like to contribute. So that was sort of my little spiel.
Thanks, Jo. I'm just looking at the time, and I'm aware that we have about 15 minutes left because we had to finish about 20 past 7 in India. So I'm just going to ask the three of you to respond to each other's questions or queries. And Somnath, first of all, just want to underline this issue that you said about multi-morbidity and make the general public aware that if you have depression and you have, say, diabetes or hypertension, that means you're going to do worse with regard to your diabetes and hypertension. Or if you have diabetes and hypertension, you might be more susceptible to develop depression or maybe cognitive disturbance. So there is an interplay, and I think Somnath emphasized this whole issue of the interplay. But the important part, which he also said, is that even in places like the Western world, more so in the Islamic regions, most people are not diagnosed. The hypertension, diabetes, depression, forget depression, hypertension, diabetes are not detected. And even if they are on treatment, treatment is not continued. So what are the choices, Somnath, with regard to aging well and being healthy aging? I know WHO has declared, UN has declared it as the decade of aging. So what really will help in terms of intervention so that people can age well?
Yeah, so I would say two things, right? One is, as I said, health services cannot be siloed in older adults. It shouldn't be siloed anywhere, but even more so for older adults, simply because of the reason that you just elaborated, which also means that we need to sensitize the healthcare providers to at least look for common mental disorders, right? And intervene with those common mental disorders as much as they would intervene with the physical disorders as well, because that is the only way to actually produce the optimum outcome and not have the person being shunted from one place to the other. The second thing I would say is really the other sort of interventions that we need to provide to improve subjective well-being and reduce loneliness. And what I mean by that is, as I alluded to, I think there are very clear interventions that one can actually provide to improve the time use of older adults. Because what we do see very clearly in our studies is that as people grow older, the repertoire of activities they engage in tends to shrink. And that shrinking of the repertoire actually leads to declines in subjective well-being and increases in loneliness. So I think there are several interventions that have been tried to actually increase the social connectedness of older adults and improve the quality of time use that older adults have. I mean, there are many such examples, right? I mean, whether it's to do with volunteering, whether it's to become actively part of other social groups, whether it's environmental modifications to enable older people to go out and, to be in parks, or, so even simple interventions like providing social benches. So there are many such interventions which are actually cost effective, which I think we need to engage in.
Yeah, thanks, Somnath. I have this fantasy that if we were to do primary prevention, in the sense that, because after all, the risk factors for health and mental health are really common. There are about 12 or 15 common risk factors which impact everybody. And that's the same for young and old. I have a kind of fantasy that, if you were to do mass public education about these risk factors and get people to help them to go for intervention and get them to intervene, that might help a lot. You think that's something that's possible? Because when you do mass education, and if people were to actually reach out and do self-care, all of us are familiar with the WHO pyramid, where self-care is really something that is very important. We saw that to a large extent during COVID, because during COVID, there was so much of education and so much of awareness that everybody did things for themselves. they might have overdone things, but you think that's a solution to this whole problem? Because you said that health services are never going to be able to pick up.
Yeah. So my pet peeve here actually is that I think if we have to deliver interventions at scale, I don't think it can be done by people. I think we have to actually harness the power of digital technologies, and coupled with the use of digital technologies, actually use behavioral insights. Because I think one of the biggest problems we have is, first, I mean, besides the detection piece, is I think adherence and compliance. And if a person has to be nudged into self-care and adherence, I think the only way to do that, in my view, is to harness the power of digital technologies and use behavioral insights to do this.
Yes. Together with that, doing it in a very large way, I guess you also need policy and programs for the government, isn't it? Again, something that we saw during the COVID, that unless you have a policy, and I think Joe is somebody who's done some work on this, looking at policies and how policies might actually impact whether people, whether you can pick up people who have disease, or whether people will actually go for help, or people will seek help themselves.
Can I make a comment
Joe.
on
Joe.
digital health? So that's, as you know, Matthew, that's one of the areas we work a little bit in terms of more health promotion around dementia, but and supporting carers of people living with dementia. But so we work with cultural and linguistically diverse communities here in Australia. And the problem is with digital health is sometimes older people are just not digitally literate. So, that's a real barrier in terms of using digital health strategies. So, it has to be a multi-pronged, I suppose, approach where, people are first upskilled to use those facilities, and also then being able to recognize the importance of mental health. Not everybody wants to talk about mental health, so it may have to be wrapped as something different, well-being or, something. So yeah, that was just a comment that I just want to put out there, especially talking about other people. Yeah, so I think, once I'm 65, hopefully I'll just be able to click a button and I'll be happy and it'll be fine. But
yeah. So anyway, to what Somnath said, I think Britain is the only country which has got a minister for loneliness, I believe. Yeah. So Mala, what are your thoughts on how to address this imbalance? And it's really an imbalance because, as we all know, older women are more prone to have anxiety and depression. Older men are more prone to have heart disease and strokes. But if older women were to get them, they would actually die as a result of that, while the men might actually survive. Alcohol and substance use is much more common among the older men. That's much less, at least in our country, among the women. So how do we address this? I mean, women are living longer. There'll be more women who are older than men, even in our country. So what are your ideas about how we're going to address this?
Thank you, Matthew. It's an important question. And I feel that for addressing geriatric mental health issues for women, the need of the hour is to increase awareness on mental health concerns for women. I mean, we have in societies a total neglect of emphasis on women's health, and very little is being done in terms of policy interventions. And we have to focus on capacity building for care providers to take into account the specific needs of older women. We need to strengthen training and research activities related to older women. There is still not enough understanding about what are women's diseases, what are women's health concerns, what are their various kinds, and why they get into depression and so forth. And we need to develop community-based rehab programs. I mean, in many communities, we don't find provisions for women. I mean, even to the extent that where we have find in some developing countries, senior citizens associations have come up where senior citizens community centers have come up, but recreational needs for women are quite limited. So the emphasis on women's health, including mental health, is very limited and is low. So we need to develop a very holistic primary health care and community care system, which is very gender centric. And also the fact that there is always reluctance in many societies to seek treatment for mental health disorders. And this is more so among women because I think right from a young age, culturally, especially in the Asian societies, we find that their health needs are not given importance. Forget about mental health, even physical needs are not given importance. So we have to find out how to encourage women to come forward and seek treatment for them. And also, I think a lot of health professionals are discovering that treating women requires a different approach than is used to treat men for the same illnesses. And it is being seen that women experience symptoms in quite a different way from men. But at the same time, they are ashamed to seek help for mental disorder. And they don't even they are not even rather aware that their symptoms can constitute an illness which needs treatment. I mean, they're so used to living with their health handicaps that they don't even see it. And this is something which is coming through even in the LASI study of India, which is a large study of at the national level. And it has also, I think even Somnath would probably find that in the SAIT study, responses by women and for women is quite limited. And I think we need to improve, take a step towards having more provisions for diagnosis and treatment for mental health conditions for women. And one of the things where you pointed out yourself is to improve education, provide more information about the prevalence of mental health illnesses, discuss the negative effects it has on women and families, and sort of give more emphasis on treating women because of their any health needs and so forth. I'll stop
Thanks,
here.
Mala. Yeah, I'm sorry for cutting in because I find that we have exactly 2 minutes left.
Yeah.
So any quick thoughts from any of you all, anything which you have not mentioned, because all of you have emphasized on the issue of large-scale interventions, rather public, making digital health and scaling up, looking at old people in a different way compared to other people, meaning addressing their problems specifically, and then of course looking at the gender disparities and looking at them differently. So any quick last thoughts from any of you? Somnath? Or Joe? You're muted, Somnath.
Yeah, yes, I mean, one thing I would like to, it's interesting to hear Mala speak because in Australia, women are more likely to seek help. Not that they do enough, and there's just so many interesting issues I'd love to discuss with you. But anyway, but I think another important issue is to consider that not everybody reacts in the same way to interventions. So it's really important to also tailor interventions to the individual because otherwise they're not going to be impactful if it's just a large scale, cookie cutter approach. I think that doesn't work either.
Yeah, thanks, Joe. Somnath, you were saying something. Final words. Yeah, now you're unmuted. Muted again. You're muted again. Yeah.
Yes, it was being automatically muted. But yes, so I think just following up on the gender issue, I think consistently we show that women have worse health outcomes than men, right through the lifespan, which is sort of what we refer to as the gender paradox, right? Because women live longer and yet they spend a much larger proportion of their life in poorer health. And that is in and of itself a challenge. But more specifically with older women, I think the two issues which strike me are, typically we have believed that women have a larger social network and they're more socially connected than men. But that doesn't seem to be true, at least in relatively low resource settings, at least in our studies. We don't see that because that is supposed to provide some sort of a protective effect for women as they grow older, but we don't seem to see that. And secondly, the caregiving burden, I think, is substantially more in older women than in men, which also therefore has a big impact on their time use and therefore their subjective well-being. Both of those things, I think, need to be addressed.
Thanks very much, Somnath. And thank you very, very much to Somnath, Mala, and Joe, especially Joe, for whom it's almost time to sleep. And thanks very much to YILAGA and Sally for having us on this panel. It was a very interesting discussion. And I think we've just exceeded by about a minute or two. So back to you. Was it Sarah? Or was it Sneha? Okay.
Me.
Thank you.
Thank you, Dr. Matthew, Dr. Somnath, Dr. Mala, and Dr. Josephine for bringing to the forefront the multitude of factors that affect one's mental health. Digitization holds significant promise for societies with aging populations as well as for older persons themselves. While digitization does bring associated barriers, let's take a look at some of the critical barriers that digitization does help to overcome. Up next, we have a panel discussion on digitization for the aging population, chaired by Mr. Chako Palatucheril. Mr. Chako Palatucheril is a treasurer of YILAGA and one of the directors of Yohans Vimukthy International. He studied engineering and worked in multiple roles, applying technology to solve business challenges. Mr. Amit is a seasoned professional with extensive experience in management, strategy, consulting, and technology across high-tech and healthcare industries. A computer engineering graduate from the University of Mangalore in Southern Asia. He is currently the co-founder and managing director of a data science-backed technology startup focused on healthcare. He lives in Singapore with his wife and son. Dr. Sejal Jayakar is an accomplished healthcare professional with over a decade of experience in the industry. Her expertise is with strategy planning, designing, and implementing processes, improvements at medium and large healthcare organizations. Her practice accomplishments include a high patient safety record and improved compliance rates for physicians. She has trained leadership teams to maintain organizational excellence. She has worked in the Middle East, Indonesia, and presently resides in Singapore. Please welcome Mr. Chako Palatucheril, Mr. Amit, and Dr. Sejal Jayakar.
Welcome to the panel discussion on digital aging as part of the YILAGA conference. My name is Chako Palatucheril, and I'm joined by Amit Bangera and Dr. Sejal Jayakar. Amit is a tech entrepreneur producing solutions for the healthcare industry. Prior to this, he was a data scientist at the Hewlett-Packard company. Today, his company, Supio Now, is harnessing the power of data and has achieved over a 50% reduction in patient waiting times across hospital care pathways. In just 2 years of startup, they have customers across 4 countries and growing. Welcome, Amit.
Thank you, Chako. Hello, everyone. Good morning, good evening, wherever you are. It's an honor to be part of this discussion, and especially on this forum, I do appreciate the opportunity. I'm really looking forward to a productive conversation and also provide my perspective of what I think is a very imminent and a real-world issue. Happy to be here.
Thank you. Dr. Sejal Jayakar is a medical doctor by education and training. However, she made the interesting transition to the quality of healthcare delivery. She is a Six Sigma Green Belt and a practitioner of continuous quality improvement. Dr. Sejal is no stranger to technology and advocates its use in her work as a consultant to various hospitals. Welcome, Dr. Sejal.
Thank you, Chaco and Amit. I'm looking forward to having an interesting discussion and being able to put forth our ideas towards the adoption of digital technology for pediatric care. Hi.
Thank you. So given the limited time that we have for this discussion, we will not be able to incorporate a Q&A session that involves the audience. However, I do urge you to email your questions to the address that the organizers have shared with you, and I assure you that they will be answered by the panelists in due course. I intend to use the contents of the whiteboard to guide this conversation, so do allow me to describe it to you. At the lower half of the whiteboard is a graphic that has been sourced from census.gov. And it's pretty interesting to note, and this will form the basis of our discussion. On that graphic, you see two graphs. The one on the left is the demographic distribution by age in the year 1960. The orange portion depicts female populations and the green male populations. At the base of that pyramid are the infants, and at the top are 85-plus-year-old people. As you can see, the one on the left, the demographic distribution 1960, is a stable pyramid. The one on the right is the projected age distribution in the year 2060, not too far away from where we are presently. And again, it's the infants at the lower part of the graph moving up to people over the age of 85 at the top. So you can see that there's a shape shift from a stable pyramid to a pillar. That's for one country. From what I understand, what I'm given to understand is that pillar on the right is starting to be loaded on top. And that is the essence of what we are calling the onset of aging population, the rapid increase of this population. The number of older adults will soon outnumber children. From a stable pyramid to a pillar, the gray tsunami will be upon us sooner than we think. So what are the stages of aging that I am interested in for this discussion? The first is interdependence, where people rely upon one another, typically in a setting of a home where one spouse depends on the other. It's a give and take relationship in terms of supporting one another through this stage. Dependence is when one or both partners actually have the onset of a debilitating progressive degenerative disease, and the care that's provided by the other was not sufficient. Outside skilled caregiving is necessary. The end of life needs no explanation. It's time for us to leave. On the left, the technology adaptations to aging. I asked Amit to name 3 trends that he thinks will be contributing to support the initiative providing healthcare to the aged population and cope with this explosion as I just described. And his response are on the whiteboard. The ables, as he calls them, the communicables, the wearables, and the detectables. On the right side is Dr. Sejal's points about the quality of healthcare delivery to the aging population. And on her list are adoption, privacy, and alert fatigue. So having framed this conversation that we're going to get into, first, let me turn to Amit and ask him to present his views on the application of technology in digital aging. Amit?
Well, thank you, Jaco. And I think it's the perfect way to put that in perspective, right? And like I mentioned earlier, it is what I believe is an imminent reality that will meet us sooner or later, right? The population is aging, and there's already a gap that we are seeing between demand and supply, meaning that availability of healthcare resources is already inversely proportional to the need, and that gap continues to grow, as we know. So I think there is a need for somehow to minimize that impact. Otherwise, it will turn out to be very severe. And so that's the question. And how do we do that? So the simple answer to me is nothing but technology, right? Even if I speak in today's context, it's only 20% of the world's population that has access to some kind of decent and safe healthcare, and it's already costing $8 trillion to the exchequer, right? And that's up from what it was $4 trillion in just 20 years back in 2001. So in just 20 years, we've doubled the cost of healthcare, obviously because more people are needing it. And so some point in time, let's say 50% of the world's population needs some sort of healthcare. That's essentially doubling today's number, right? And that would mean that your cost also is exactly the double. It's now $16 trillion. Where is that kind of money coming from, right? Is it practical? So how do we do this? And like I said, the simple answer is technology. We got to double the number of patients without increasing the cost significantly, because the need is going to be inevitable as we go along. So like I said, it's the simple answer is nothing but technology. Let me give you a simple food for thought, right? Apparently, and this is just information that I've read on the public domain, and I apologize if I'm crossing boundaries here. I'm not a clinician, but let's just say, right? Apparently, 99% of the patients that are unwell do not need to be operated on. What that means to me is, if the doctor does not have to operate on a patient, he does not have to touch and feel the patient, which also means that the doctor and the patient do not have to be sitting in the same room. So essentially, what the doctor needs is information and data, right, to execute what's called as objective diagnosis on the patient. So to me, if I look at it again objectively, it's just a very simple two-part solution. One part is there has to be a way for the doctor to be able to communicate with the patient. Let's say like a video calling feature or functionality. Now that's what I call as a communicable, right? And the second part is really a way to acquire the data, right? That a doctor needs from the patients to execute his diagnosis. Now, if you look at it, Jaco, it happens even today, and a lot of what defines the patient's condition when you go to a hospital or a doctor's clinic, a lot of what defines the condition of the patient is really based on the data that is output out of the devices that are being used to diagnose, right? Like as simple as a thermometer for your body temperature, could be a BP monitor, could be an oximeter, could be a blood sugar monitor, or even an ECG, something complicated as that. It's just that it's done in person, which means somebody is operating on those devices on behalf of the patient and collecting that information that goes to the doctor for his diagnosis. But you must understand that there are next generation devices even today as we speak, to what I refer to as the wearables and the detectables, that can acquire the exact same data remotely, and then you can decide what you want to do with it. You can either transfer it to the doctor, or you keep it in some place for future reference whatsoever. But the data can be acquired remotely. I think that's what I'm trying to hint here, right? So, for example, the smartwatches that we wear today, they have the capability of measuring blood sugar. They have the capability of measuring pulse rate, and as a matter of fact, some of them have been enabled to detect fall, which means if there is a fall, the device is programmed to send triggers, automated alerts to either the relatives or could be the doctor, so whatsoever. And then I've known of some portable and Bluetooth enabled ECG machines that are also available in the market. Now, here's the thing, right? Interestingly, Chaco, as we talk about, how we can get more people, accustomed or on board of these platforms. Interestingly enough, we've had this kind of experience, or rather, we've gone through a trial run of all of these technology-oriented healthcare service during COVID, right? And if you remember, wherever there was a lockdown, almost all primary healthcare was being delivered, through telepresence. So we've already got a touch and feel of that in that period. So I think point that I'm trying to bring here is, I think if the faster adoption of such technologies, I think will significantly reduce the gap between demand and supply as more and more of the population would seek quality healthcare as we go along this trajectory. That's what I'm trying to say. Thank you.
Thank you. Thank you, Amit. And that was a clear articulation of the role that technology will play in the delivery of healthcare to senior populations in the not too distant future. And the examples that you shared on each of the three trends, the frontline trends, if I may call them that, where patient facing, the communicable, the wearables, and detectable are certainly illuminated. Thank you. Dr. Sejal, I now turn to you. As I said earlier, since you're familiar with the adoption of technology and the use of technology in the delivery of healthcare, I expect that from a quality angle, you will take a cautious and metered approach to adopting technology. So could I please ask you to share your thoughts on what the aspects of technology adoption, privacy, and alert fatigue are the areas of your focus?
Thank you so much, Chaco and Amit. You've been bringing such interesting points to view about the use of technology. And I'm looking forward to bringing my concerns also on the same table in this forum. We know that we are discussing digital aging and zero technology. We are trying to identify the technological needs that our elderly patients would need to use to assist them for their healthcare decisions. Even with all the points that have been mentioned by Amit, I agree. We have a lot of instruments that assist the doctor in coming up with his primary diagnosis. But I want to emphasize, we cannot deny the impact that the simple presence or the touch of a physician in the consultation room makes. That kind of effect cannot be duplicated, no matter what type of technology you're using. Retelling, some of the very few statements that we hear often from our patients is that you have been our family doctor for 3 generations. We always get better very fast the moment I step in your consultation room. We receive care from you and we are up in a jiffy. In my personal opinion and from experience with handling these senior citizens, a proper physical examination cannot be substituted, may not be substituted with any amount of technology. No matter what we do, sometimes that placebo effect, that basic human touch, is the required effect that is needed. Yes, you will have the technology, you'll have all the remote devices, but not having the presence of that physician does make a difference. Again, we have pointed out, we have had this trial run. Digital technology played a pivotal role in bringing the required healthcare needs to the elderly. We have seen this, as we said, in the last 2 years. We had so many lockdowns. We had so many quarantines. We had so many stay-at-home notices. We have all gone through that. And if your care, you were under the elective care process, your healthcare needs were put on a hold. If you didn't need to see the doctor offline, you were managed by teleconsultation. How? You were managed on phone, directly on the phone. You had different apps to use it. You were using FaceTime with your doctor, but the satisfaction rate wasn't there. All this occurred, and the result was we hope that there would be widespread adoption of this technology, especially in the elderly. But sadly, this percentage is far below, almost less than 10%. It's inversely proportional, as we all say. They need it the most because they need to reach to their doctor, and they are the ones who are using it the least. Yes, they have various members in their life who are using this technology for them. Sorry. They have their sons, they have their daughters, they have their caregivers who are using it for them. Elders find technology use cumbersome. They find it complicated. They don't want to use them. They said he or she is using it, they're using it for my care. Let them take the decisions. Even though they want to feel empowered in their own decision making, they sometimes step back before using it. They think, what if my data got stolen? Or they think, what if I'm being scammed? There is a mistrust there. They have this issue with their privacy. Sorry. My family and caregiver are using it. Why should I use it? You see so many incidences of data breach that result in this mistrust. The point of fact being that the adoption is low, which is resulting in this mistrust. And adding to this are their various comorbidities that they acquire when they reach 60 and 70 age groups. It's like they have physical impairments, they have sensory losses, decreased cognition and perceptions. All this is still, these are the concerns only from the patient side. Let me divert these concerns from the patient to the caregiver. They are the ones who are using the technology for the elderly. And a very worrisome issue that keeps coming forth for us is what we described as an alert fatigue. You have so many incorrect system triggers. The devices are not maintained properly. A single physician is taking care of so many patients. His staff is having so many alerts that are coming in. There is a tendency of overlook. There could be a tendency of desensitization. There's a tendency of being overwhelmed. All these factors could result in hampering the patient care. A very possible, unthinkable situation could be leading to cross morbidity and mortality. So when you have such a fast-paced growth and equally paced need to adopt it, it makes us take a step back. Caregivers want to take a step back to review and look at them from a different angle and say, hey, hold on. We need it streamlined for us. We need it more secure for us. We need it to be more adaptable for us. We need it to be able to use it on a single platform. And can this be done? And this forum is probably the right place to pick up these issues and let it out. Let my colleague, Amit, and you help me figure out how you can handle my concerns and make this adoption much more easier. Thank you.
Thank you, Dr. Sejal. And these are facets of a cautious approach that certainly need to be given its due consideration. Amit, there are a couple of aspects in what Dr. Sejal said that I'd like your comments on. The first was, on on behalf of the aspect of using communicables, right? Elders typically outsource this to the younger generation to handle their communicating using devices. So one question I have is, how can that requirement be incorporated? Secondly, and I think this is important too, which is, Dr. Sejal described the relationship that general practitioners have with their patients, which includes a lot of face time, in presence, see, touch, feel. So how would you strike a balance between teleconsultation, telepresence, telemedicine, whatever label you put on it, and the need for the caregiver's human touch?
Yeah. I guess it's a very relevant question, Chaco, and I mean, I agree that human touch cannot be replaced at all. At least we're just designed that way as human beings, right? And I think for most of the, actually not most, but all of the emergency cases, like let's say we take ER as an example, right, of any hospital. I don't think ER can be dealt, emergency cases can be dealt remotely. It's impossible. So I think for all emergency cases, it's going to remain that way. But let's be practical about it, right? ER emergency cases just account for about 5 to 10% of the total. And for the rest, who just come to see a doctor, it's about really, today you're okay to stand I mean, you're okay to wait in the queue. But I think where we are heading, it's about choosing between to get the required attention. If there's a choice between getting the attention quickly remotely versus not getting at all, which one would you choose? Right? Because why I'm saying that is, right now, we're seeing that the gap is growing. There's a continuous gap growth. Sorry, there's a continuous growth in the gap between demand versus supply, and what is today a 2-hour waiting time may end up to be 10 times when 50% of the population is expecting healthcare. So I think my opinion is that although there is a human side to how healthcare has been delivered traditionally, but at the same time we got to start thinking and getting more pragmatic about where we are heading, and really start preparing ourselves for the trade-off that comes along, and the greater good that comes along with the adoption of technology, because there will be a time when you would not you would not feel the same sitting in the ER like it is today, and I don't think you will be happy waiting for 10 hours to just see a doctor where they can do it remotely, right?
Yep. Dr. Sejal, given that the explosion of aging populations will occur, that's a fact. So the way I see it, caregiving will have to make the transition from a retail mode to, where a GP sees a limited set of patients, to a wholesale mode where the number of patients vastly increase. The doctor to patient ratio is going to drop. It's only going to drop, right? So I'm going to guess that there's going to be some modification to the stance your stance that the human touch of a GP face-to-face consultations is going to undergo some kind of transition. So what will that transition look like, Dr. Sejal?
That's interesting, and somehow very true in the right direction. And that's what we have been trying to advocate as well. When you said that I'm advocating technology, this is where the advocation comes. We all have to go into work a little more harder. We have to try and find ways to merge with these technological advances. And the foremost thing that comes to my mind is that we need to empower and evolve our primary and secondary caregivers. We have to understand in developed countries, the tertiary care organizations, even in most of the developing countries also, the tertiary care organizations have the technology. They have everything for them well said. But what about the ones who are seeing the patient first? What about the ones who are the primary and the secondary caregivers? You have to evolve them as well. You have to bring them under a unified umbrella, give them the same kind of technology, give them to them on a platform where they are able to get that data for themselves as well. Imagine the times that a primary care physician has to go back to the tertiary care, ask for the discharge summary or something like that, to find out what has occurred with the patient in between the two visits. If he could pull that data and get to see it, the time that he would need to spend on that single consultation will drastically reduce. So again, when we talked about from the retail to the wholesale, this is one of the ways that it will differ for them. But again, because it is unavailable to them, because it's not user-friendly for them too, they are not using it. So what is going to be the key factors here? You're going to have to educate them. You're going to have to train them, be it the caregiver, be it any level of the caregiving, be it the patient, the doctor, counseling, training, education. And they are the ones who are going to drive your technology home. They are the ones who are going to make it adaptable for everybody. And if you do not bring them under a platform, then it is going to make it, then it's not going to be easy. So this is where I would say that, okay, when we're going from the retail to the wholesale, this is what is going to be the difference that we need with our GPs. Thank you.
Okay. I'm going to stay with you, Dr. Sejal. So, with huge amounts of testing that we certainly got a glimpse of it, for the past 2 years during the pandemic, patient records, lab records, radiology reports, all of these are just going to grow exponentially, right? So, and it's going to be at the cost of patient privacy, if I may put it that way. So here's my, patient privacy may need to take a backseat during the course of the delivery of effective elder care. How does this sit with you?
Very uncomfortably, if I may say. It's a catch-22, right? Like nobody wants to have any of his financial data being shared, right? Healthcare data is becoming as important as any financial data because it is attached to a wealth generating industry, right? So what happens is in this one side of the situation during the whole pandemic, we had a very good advantage when the data was being shared with us. All caregivers at any level found it much more easier because they had information from various sectors, from different sources, from different countries. And they could manage their patients more easily. They could manage their populations more easily. We got information about how the vaccines were handled or what are the side effects. So all that data sharing was very advantageous in this kind of a pandemic situation. But on the flip side, so much data got leaked. Wasn't that where the mistrust started, right? So much data was getting leaked at the same time that everybody was concerned. And then the whole hula happens about, oh, this data is gone, this data is gone. Yes, how will we handle it? And the only way I can see it is when I approach and have an appeal towards my regulatory bodies. You have your government, you have the different guidelines that are there. We request them to make more strategic policies. We request them to have more oversight. There should have to be strict monitoring on this. If this is not there, we are scared to share the data. We don't know what to share. We don't know what is applicable in sharing. So even though we want it, we are concerned and we take a step and say, hello, is this possible? Can the regulatory body make it in such a way that we can take a front seat in care of patients and taking a front seat towards caring about the data? So I hope, again, we have an answer to that as well. Thank you.
Yeah, and certainly, we do have the HIPAA regulations today, and numerous other ones that protect the privacy of the patient. But Amit, regulations are often viewed as a roadblock to the innovation and the development of technology, at least in my mind. So it looks like, with this growth in the technology and the growth in the outreach that you are projecting, we will certainly have to factor in that regulations are going to be increasing as well. How do you, if I may put it this way, maneuver around that or accept it and still be able to deliver effective healthcare using technology?
Right. And I think Dr. Sejal kind of nailed it, right? To me, actually, it's as a matter of fact, right? It's to the extent of today, securing patient data is more important than patient health. I think that's where, if I can put it that way, right? That's where we are, and therefore, to kind of address Dr. Sejal's concerns, and they're not her concerns. I think I would have the same concerns as well because my data is out there, and I think it's a universal concern. So therefore, there is significant investment required today, by firms that provide healthcare services, even operators themselves. They invest a lot in security protocols and ensure regulatory compliance is being met, right? And so when there's so much focus on the security side of delivering healthcare, you obviously will see innovation slowing down, and that in turn affects adoption. It's as a cascading effect, right? So there are issues today, but with the advent of more inherently secured backbones like blockchain, right, and their large-scale adoptions that we foresee in the future, these are virtually unbreachable, and As I said, when there's going to be large-scale adoption of such platforms, I see that the focus slowly would move from security towards innovation, right? And that's just a matter of time. When that happens, I think that's the point when we can democratize healthcare. I think that's the way it should really be, as a fundamental right for every human being, right? Like I said, I think we're getting there. It's just a matter of time. So yeah, I'm really looking forward to it.
Right. So it sounds like technology is going to improve, and technology will solve the problem of privacy as well. And now we've run out of time, so let me wrap up a pretty energetic dialogue that just took place. In a rapidly aging world, multidimensional systems will be needed to cope with the sheer increase in demand for caregiving to the aged, caregiving for the aged. And technology is one important system that we just got a glimpse of. Things such as telemedicine, telepresence, and are and will occupy a prominent position in the tech portfolio in the years to come. Adoption will be a critical success factor. Caregivers, such as general physicians, will need to advocate the widespread use of this technology and advocate remote consultations as well. Privacy controls will probably look different too, while standards and regulations are already in place. With the sheer volume of patient records and results increasing, there are promising technologies such as what Amit mentioned, blockchain, and these seem to point the way to a better preservation of patient privacy. Well, there's so much yet left to discuss, and I wish we had more time, but we don't. So I have to bring this discussion to a close. Thank you both very much for your involved participation. Thank you, Amit. Thank you, Dr. Sejal.
It's great to be here. Thank you. Thank you for having us.
Thank you for having us. Have a good evening.
Thank you, Mr. Chako Pallathucheril, Mr. Amit, and Dr. Sejal Jaikar. This leads us right to our next session. Inclusion is not simply about physical proximity. Up next, we have Dr. Alakananda Banerjee bringing to our attention on how the aging population in remote villages of India are being aided with healthcare and awareness programs. Dr. Alakananda Banerjee completed 25 years of corporate hospital industry, where she worked to set rehab guidelines to acute and subacute care. Her desire to influence social impact was finally fulfilled when she became founder chairperson of Dharma Foundation of India. The foundation focuses on prevention and early detection of non-communicable diseases prevalent in India, including mental health in elders. She focuses on developing health literacy platforms, which will create communication between healthcare providers and patients in these communities, while also focusing on improving continuity of care. Please welcome Dr. Alakananda Banerjee.
Good evening, friends. I'm Dr. Alakananda Banerjee, and I thank you all for giving this opportunity of sharing the work done by our NGO, Dharma Foundation of India. The objective of our NGO, as explained by Jane yesterday, it is actually understanding the environment and place of an elderly. So this is the process flow. You can see we select an elderly organization, then we train the elderlies and distribute booklets on health. So we are a group of healthcare providers providing health literacy to our trainers. And then we form small groups, and these volunteers take care of these groups of people, and the social interaction is done by the WHO guidelines of active aging, which is self-care, mutual health, and self-promotion. So these organizations, some may have a center, some may not have a center, but what exactly do we do, using the communication technology is something that I'm going to explain. So health literacy is the process of understanding my health. Like, I'm 62 years old, so I have to understand my health. As you know, if you type my health condition in Google, there's either too much of an information or too little. So I'm confused. I am scared. Yeah. So this type of a literacy that we are doing in the grassroots level is actually empowering the people to understand about their issues. I have mentioned a particular website where I have taken the paper which has been published. The health literacy model was prepared by a Swedish organization, where we have implemented this health literacy into the active aging model of the WHO guidelines. Yeah. So health literacy is not anything but be literate as we understand education. So we are making people literate on their health. And one thing I just want to tell you, we are just making the literacy on non-communicable diseases. So they are like arthritis, cardiac issues, stroke, Alzheimer's, dementia, Yeah. So it's not communicable diseases like COVID, dengue, malaria. No, it is just on the non-communicable diseases. As the WHO says, the concern in today's time about the overflow of non-communicable diseases in the world. Yeah. So what is health literacy? Why is it important? It is important for me. Remember, I'm 62. That I may make a mistake in medicine usage. I may, actually not understand that I need to see a doctor. Yeah, that makes a higher risk of death. And also, this is very, very relevant in the place that we work in remote areas of India where they have got no doctors, or they may have some chemist shop which may have a doctor in the evening. So, and how helpless that person in those remote areas will be. We've heard about it from the speakers yesterday. And this leads to more hospitalization and more burden on the government. So what are the three basic is prevention of diseases, early detection, and third is the functional capacity of the elderly within his biopsychosocial model, of his living. Okay. So what do? We do teleconsults. Yeah. We use the communication technology. We are trying to make an app which we are hoping to get some funds from the Department of Science and Technology. So the health literacy, I'm sitting in Kolkata. So I can actually take care of a patient in the remote area of Darjeeling. I was just in Darjeeling, where the remote and the rural area of Darjeeling don't have the the accessibility. They have to come to Darjeeling District Hospital. So these rural areas, the volunteers are trained on two aspects. One is through, you can see the picture, through teleconsults and we use just WhatsApp video, as simple as that. Yeah. And luckily in India, everybody's smart. Yeah. Using smartphones. That's actually post-COVID, we have noticed it. So, so when they come, they have a patient of knee pain. Yeah. So you can see that they are there. The patient is there and I'm there. Yeah. I'm sitting in Kolkata. I have my team of doctors, a neurologist, a cardiologist, and a spine surgeon who's sitting in Delhi. So we are giving free teleconsults. Now the supervisor, the volunteer is knowing what to do. Yeah. Initially, knee pain hai, okay, we can take care of it. If we cannot, ma'am is there, we'll call her up. Yeah. So participation of volunteers, like we are doing workshops also once in a month, along with teleconsultation, where it's an on-the-job training, is something that Dharma Foundation does. So you have got one picture of a patient who has been post-COVID, and you can see he had bilateral facial palsy, how he improved through teleconsults. Yeah. So what is the benefit? The benefit is definitely we can prevent and protect health problems, improve their communication with the doctors. Yeah. See, now we have to meet better treatment and better productivity. So, keeping with the SDG guidelines of the third guidelines of well-being and health, we are actually following this in the remote areas with the motto, no single person will be left behind. It is a difficult task we have done. We were established in the year 2010 in New Delhi. We have worked from 2010 to now. Of course, we had a gap of 2 years in different places of India, like Belgaum, Latur, Haryana. Haryana was I won't go to the place. Chandigarh, Gurgaon. Then we have worked in Visakhapatnam, etc. Presently, we are working at District Bankura in West Bengal. Yeah, it's called a place called Khatra, which has 2 lakhs population. And we are hoping to work at Darjeeling in the next few months. Yeah. So thank you for giving me this opportunity, and All the best for all of you. Thank you.
Thank you, Dr. Alaknanda, for the interesting presentation. Coming to our next session. A vast population of the world, especially the older generation, suffer from various types of chronic diseases. And it's important for them to know how to manage one's chronic disease in the most productive and positive way. It is my honor to introduce a pioneer and luminary in the field of chronic care and disease self-management, Dr. Kate Lorig. Dr. Lorig is Professor Emerita at the Stanford School of Medicine and a partner in Self-Management Resource Center, which offers self-management programs in 30 countries. She has spent the past 40 years developing, evaluating, and putting self-management programs into practice. Among others, she has worked with the United States Center for Disease Control and Prevention, the Pan American Health Organization, the National Health Service of England, and the Salvation Army in Hong Kong. Her present research interests include internet-based diabetes self-management, as well as small group interventions in diabetes and arthritis for English and Spanish speakers. She has published several books and journal articles in these fields. She is the recipient of multiple awards, including the Molly Mettler Award from the National Council on Aging Health Promotion Institute. She is the recipient of several other awards in health education. It is with immense pleasure I present to you Dr. Kate Lorig.
Good evening. I am so happy to be with you all from half a world away. As I speak with you, it is early morning near San Francisco in California, and I wish that there weren't many oceans between all of us. But I hope that to take you on a short journey about self-management, what it is, and how it can apply in hopefully our lives in the United States and your lives in India. Next, please. Let us start by defining exactly what is self-management. This is a definition that is used fairly broadly worldwide. It originally came from the United States Institute of Medicine. Self-management are the tasks that individuals must undertake to live with one or more chronic conditions. And these tasks include the confidence that they can deal with the medical management that's taking their pills, doing their physio, their role management, doing the things in life that are important to them, working, being a grandmother, etc. And finally, the emotional management, managing things such as depression and fear that often come with chronic conditions. I will also note that the drawing here, Australian, it was done by Aboriginal people, of their interpretation of what self-management means. And underneath it, it says, people looking after themselves and each other. So now, shall we go on to the next slide? Why should we even care about self-management? Well, the reason that we should care is that people with chronic conditions live 99% of their time outside of the healthcare system. And it's during this time that they are self-managing. They can do that well, or they can do it not so well, but how they self-manage greatly affects their health and their quality of life. And what we're going to talk to you about today is how people can best self-manage well. Next, please. Before we start that, let's talk a little bit about chronic conditions in India. You may all have heard this many times before, but just to remember, about 70% of all Indians have a chronic condition. Women have more chronic comorbid conditions, that just means that they have more than one condition, than do men. And the most common chronic conditions are cardiovascular disease, high blood pressure, depression, arthritis, and diabetes. And this comes from a recent longitudinal aging study by the Union Ministry of Health and Family Welfare. Next, please. I'd like to talk a little bit now about the purpose we've already talked about, that it's to improve people's lives and that of their caregivers, and also to reduce the use of the healthcare system. Next slide. Now let me talk a little bit about the Self-Management Resource Center. You see that on my name and in the logo. We're an organization that has developed programs, evaluated them, and finally put them into practice. These programs were all originally developed at Stanford University in the United States, and for the last 5 or 6 years have been managed by the Self-Management Resource Center. Today, we have the following basic programs. We have the Chronic Disease Self-Management Program for people with multiple mental and physical health conditions. We have a Diabetes Self-Management Program. We have a Chronic Pain Self-Management Program, a Positive Self-Management Program for people with HIV, and a caregiver program called Building Better Caregivers. So all of these programs have many things in common, but the content of each is different. Let us see the next slide, please. These are some of the things that all of these programs have in common. They're peer-led. There are 2 facilitators or leaders for each program, and these leaders come from the communities that they serve. They are generally not health professionals, although sometimes they are, but very rarely. We have standardized training for all our leaders, and this training is about, depending on whether you do it in person or online, it's between 24 and 30 hours. The workshops or the classes themselves are 2.5 hours a week for 6 weeks. They're built on self-efficacy theory. And all self-efficacy means if we know that if people are confident or sure that they can do something, they probably can. And if they're not confident, they probably can't. And so we do everything that we can to make people more confident they can actually do things. All of the programs have standardized format and content. So they are manualized and everything is written down in great detail. They are very interactive. It's not a teacher talking to students. It's a facilitator helping people to talk to each other and adding content. And these programs can be offered in small groups, and that's what you see here, or they can be offered virtually via Zoom or any other platform for that matter. Next, please. So I'm going to start out by talking a little bit about the Chronic Disease Self-Management Program. The objective of this program is to evaluate the effectiveness, and that by that we mean changes in behavior, health status, and health service utilization of a self-management program for chronic disease designed for use with a heterogeneous group of chronic disease patients. This means that people with diabetes and with heart disease and with arthritis and with depression all could be in the same workshop together. And of course, many of these people have 2 or more conditions. Next slide, please. This is a study that was recently completed. I should say that there are more than 40 studies now, the Chronic Disease Self-Management Program. The original 2 in English and Spanish were large randomized studies. And these findings, which are from a recent study that was done in Europe of 5 countries, really mirrors what was found in those original studies many years ago. The study was in Spain, the United Kingdom, Netherlands, France, and Italy. It had over 1,000 participants with a 6-month follow-up. 67% of the people in this study were women, and their mean age was 61. Next slide, please. At 6 months, There were statistically significant changes in self-rated health, which is one of the very best predictors of future health, in disability. They had better social and rural activities. That means they were doing the things they wanted to do. They had less depression. They were communicating better with their healthcare providers. They had better health literacy, which means that they understood more about what was happening to their health. And there were fewer reported medical errors. Next slide. Remember that I said that there were two objectives. One was to improve the quality of life of people, and that we saw that in the last slide. Here we see the reduction in healthcare costs. There were fewer physician appointments. There were fewer emergency room visits. There were fewer nights in, looks like we're missing the word hospital there, but there were fewer nights in hospital. And the average savings in this study were about 307 euros per participant. That means that they reduced their usage by about 620 euros. The workshop itself costs about 300 euros. And so the savings were 307 euros per participant. Next slide, please. Now I'd like to show you very similar information for the diabetes self-management program. Please don't worry, I'm not going to show you all 6 programs, just these 2. This program is very similar to the chronic disease self-management program. It is a 12-month study, not a 6-month study. The program is different in that the content of the program is very diabetes specific. This particular program is available in English, Spanish, and Chinese. And again, it is taught by peer leaders. This study was conducted by with patients from one of the large insurance companies in the United States, with approximately 1,200 people. Next, please. So how did the outcomes affect people? We talk very often about the triple aims. They had lower A1Cs for people with an A1C over 9, with at 1 year, their reduction in A1C was 1 full point. A1C is the single best, probably, way of measuring blood glucose control over time. And they also improved medication and lab testing adherence. So they were taking their medications more regularly and also getting their required tests. On a population basis, they had improved self-rated health, they had improved depression, and they had improved fatigue and sleep. And now let's look at the next slide to see about the cost savings. The per capita costs, the return on investment was approximately 2 for 1. And these data all come from the insurance company's claims data. The intervention in this case costs about $400, and the healthcare savings per person were approximately $800. So you can see that the savings per person are fairly similar in the 2 studies. Next, please. Many people ask, so why are these programs effective? And we know that some other health education programs, health promotion programs aren't effective. And what makes the difference? And I think that one of the things that makes the difference is that these programs are very carefully crafted. First, they're crafted among, and we'll talk about each of these: co-creation, self-tailoring, and the role of depression. So let's look at the next slide. By co-creation, we mean that the people that we want to serve are the ones that tell us what it is we want to study. We have focus groups. We talk to people one-on-one, and we listen to them very carefully. And you might wonder what this funny slide is, this funny class. This shows you one of the advantages of the program. This is a course that is being given in a warehouse, in a poor district, mainly Hispanic in San Diego, California. And you can see that this is a place that, this is a workshop that can be given most anywhere. So we have participant interviews, we have focus groups, then we look at the literature and we look and see what has been successful, what is not. We have discussions with health professionals. And in those discussions, we ask, what are the things that are really important for people to do? Not what is important for them to know, but what is important for them to do. In most health education workshops, there are lots and lots and lots of messages. I went to 2 diabetes workshops, not our own, those given by good people in other places, and I counted that over 6 weeks, people were told to do or not do about 300 things. We try to keep our messages much, much shorter. In our workshops, in a 6-week period of time, we will probably give somewhere between 80 and 100 messages. And finally, we have ongoing feedback from our leaders and from our participants. And we're constantly making small changes when people tell us that we've gotten something wrong or that they don't understand. So this whole process of ongoing co-creation is very, very important. Next slide, please. All of the workshops have 3 core elements. Action planning. Action planning means that each week we help people to do what they want to do this week and to succeed. We don't care so much about what they do, but what we really do care about is they succeed. So an action plan may be, this week I will walk after lunch 15 minutes. Or this week I will write a letter to or an email to my aunt to find out how she's doing. They're very, very specific. The second element is problem solving. And in this case, we actually teach people how to solve problems. So when somebody has a problem in the program, what we say to them is, what is your problem? Would you like some help? And then we have people make suggestions. So the second thing you do in problem solving is you get a whole group of suggestions. You look and see whether any of those might work. If you pick one, then you try it. And if that works, that's terrific. And if it doesn't work, then we might try another suggestion, or we might cast a broader net for solving this problem. And only after none of these things work do we decide that maybe this problem cannot be solved right now. Doesn't mean it can never be solved. It can just not be solved right now. The important thing is that many people go from, I have a problem, I know there's nothing that can be done, to helping them generate ideas and try different solutions. And we do lots and lots of problem solving around the participants' own problems during the workshop. And finally, decision making. People with chronic illnesses all have to make decisions, as do caregivers. And again, we teach a very formal decision-making process. What decision do you want to make? What are the advantages and disadvantages of each? And we show them how to make an informed decision. It's not that we make decisions for them, but help them make their own decisions. These 3 elements, as I say, are used over and over again. Next slide, please. Another very important piece of self-management is self-tailoring. And so, to understand self-tailoring, we need to discuss a little bit about tailoring. In most health education, the person giving the program, the teacher, the leader, the health professional, learns something about the participants. And based on what they learn, they make suggestions. That's what tailoring is. For self-tailoring, what it means is that we give a structure and some information so that people can decide the changes they want to make and how they want to make them. Having watched this program all over the world, I can tell you that some of the problems, some of the concerns, some of the action plans are exactly the same in China as they are in Japan, as they would probably be in India, as they are in Spain. However, the way they are expressed and the solutions may be very different. And by letting people find the solutions within their own life contexts, we then get people to be moved towards better health behaviors. So this whole issue of self-tailoring is really, really important. Next slide, please. We need to talk about depression. One of the things that we have found is that about 30% of the people that come to our programs are clinically depressed, and that's using a standardized depression measure. This was also found in Spain. It's been found everywhere in the world that we've done this program. And one of the things that we found over time is that the self-management interventions, doesn't matter which of the 6 programs, actually moves clinical depression about the same amount over 6 months as do antidepressant drugs. Now, we're not suggesting that people not take antidepressants, because in some cases they're very, very useful. But we do say that cognitive behavioral therapy, as some people have found, we don't actually do cognitive behavioral therapy, but many of the elements of our programs are similar, really helps move this depression. And if you don't help people's depression, they're probably not going to change their behavior much. And so that's why I put this moving of depression as a core element in the program. Next, please. So in closing, let me just say that what we have found is that self-management is an effective and inexpensive public health intervention for assisting those with chronic illnesses. I'm sorry that I'm not going to have an opportunity to answer questions today, but please email me. I am about 30 seconds away, and I'll be more than happy to correspond with you and to answer questions and to help in any way I can. It's been my real pleasure to be with you today, and may you go in peace and health. Thank you.
Thank you, Dr. Kate Lorick. I assure you that the importance of self-management has indeed struck home. If older people can maintain their health until the last years of life, and if they live in an environment that allows them and their ongoing productive engagement in society, aging populations might instead be considered an overlooked societal resource. Up next, we have a panel discussion chaired by Dr. Varkey Palathucheral. We will hear about how cities can be planned and governed in ways that better support the needs of older persons, changing how cities are arranged and organized in terms of space, and how changing the criteria used helps monitor the effectiveness of cities. Dr. Varkey Palathucheral is a professor and dean at the American University of Sharjah. He is also one of the directors of Yohans Vimukthy International. He is a graduate of the Indian Institute of Kharagpur and Ohio State University. He has worked as an associate professor at the University of Illinois for 15 years. For the last 12 years, he has been working at the American University of Sharjah, of which the previous 6 years he's worked as the Dean of the College of Architecture and Art and Design. Dr. Sandeep Agarwal is Professor and Director of School of Urban and Regional Planning at the Department of Earth and Atmospheric Sciences, University of Alberta. Dr. Saket Saraf is an architect, planner, and has joined the CEPT community as the Director of Library Services. He is an avid library user and believes in the vitality of libraries in being the soul of research and education. Please welcome Dr. Varki Palatucheral, Dr. Sandeep Agarwal, and Dr. Saket Saraf.
Thank you, Sneha. It's my pleasure to lead this panel. And I want to thank my fellow panelists for taking the time to join me in this half-hour discussion. One of the things that may not be clear in the introduction is the three of us share a common link to the University of Illinois at Urbana-Champaign. We've three gone in very different paths. As you know, Sandeep is in Canada, Saket is in India, I'm in the United Arab Emirates, but we've kept our connections over the years. So to both of you, my thanks for joining me in this session. As Sneha very nicely put it, this panel is really interested in looking at how cities can be planned and governed. That's, as urban planners, that's our interest, and we want to do it in a way that supports older persons, right? And as Sneha pointed, there are really two parts to that question. One is, how can we change the way cities are organized and arranged, so spatially? And how can we look at cities, assess cities differently in a way that recognizes the needs of older persons, right? Why cities? Why should we talk about cities? Well, for an increasing proportion of the world's population, the cities are the stage on which we play out our lives, right? Note, we'll come back to it later, it's not everybody on this planet, but for an increasing proportion of the world's population. So cities play a significant role in the quality of our lives. Today's discussion is going to be structured around 4 points that you see on the screen. And these are points that we have taken from a report published by the Global Coalition on Aging in 2016. It was also produced by the McGraw-Hill Financial Global Institute. If you look it up online for more information, you'll find it there. And so we will use these 4 points to structure our discussion today. So my role is to ask the questions, and my panelists will do the hard work and provide answers. So let me start with you, Sandeep. So this question of, as you age, how can you continue engagement with the world around you, right? Whether it's in terms of work, continue to be educated, continue to engage in arts and cultural activities, and continue in terms of recreation, to continue to engage the world. So let me hand it off to you, Sandeep.
Thanks, Varki, and great to see you. Hello, everyone from Toronto, Canada. I actually live in Edmonton, Alberta, but I'm just traveling to Toronto. It's back to your question, Varki. The way I see the continuing education of older immigrants or older adults in variety of sectors of our lives, I sort of call that social inclusion. So just a quick stats about Canada. By 2030, 1/4 of the Canadian population will be 65 plus. So you can see that Canadian population aging very fast, especially if you compare it against Indian population. So this issue is front and center in Canada, and we have a fairly large pan-Canadian research looking at the factors that lead to social inclusion and exclusion from, you talked about spatial perspective, Varki, but I'm going to add 4 other perspectives: political, economic, social, and then obviously the geospatial that you mentioned. So very quickly about political, when we talk about political inclusion, you know, big P dimension of political is about laws and policies and programs and voting and all of that. But I think it's a small P, which is in this political dimension is more important. That is about the broader participation of older adults in civic society, knowledge acquisition, and facilitating engagement and such. Social is more to do with, you know, how to ensure that older adults have social relationship, friends, acquaintances, and things of that in nature. Economic is very important, especially in Canada. Many of the older Canadians, especially older immigrants, are engaged in precarious nature of employment and income, and that has effect on social isolation. And geospatial will get into that encompasses housing, transportation, accessibility to these aspects of space and place context. So I just stop at that, but I think I just wanted to sort of set the stage for the next set of discussions.
Right. So that's great, Sandeep. So what you're telling us is it's not enough to think of cities just as spatial entities, right? Things that are spread out in space, but they also have economic systems, they have social systems and political systems that will have an impact on things. So you're asking us to essentially broaden our view of the situation beyond of the challenge, broaden our view of the challenge beyond just the physical arrangement. Thanks. Saket, any response to what Sandeep just said? Or I want to add to it?
Yeah, I totally agree to what Sandeep said, that it's the larger, the four issues, the political, the economic, social, and then the geospatial. But what really ties all the three things, the political, economic, and social, is the geospatial location. And I think from a planner's perspective, it is the geospatial, the co-location, that actually makes or breaks the political, social, and economic inclusion of people in our cities. So yes, the larger umbrella is extremely important, and as this panel's theme is, it is what Sandeep is describing through housing and transportation, that other three inclusions are really affected.
So let me just add to that a little bit and actually pose you a question. So it seems to me that one of the issues in older persons feeling confident in engaging with the outside world, where in any of these areas, is a sense of safety and security, no? That they need to be safe, they need to be secure in reaching out. Now, we've heard so many stories about older persons being the subject of really terrible scam and attacks and things like that. So when they attempt to move out of, to reach out to the outer world, really sometimes they're taken advantage of, right? During the pandemic, we've had many examples of it. And both of you know, we did that work in East St. Louis. There were so many examples where we had elderly homeowners, unscrupulous contractors coming and telling them that they could fix their homes by taking only a small portion of the equity they own in their home and basically stripping the home of its equity, right? So when you talk about social and political, I think a key aspect of it is giving people the confidence, giving older people the confidence that they can step out, reach out and engage in this broader world without being subject to these kinds of unscrupulous people. Any reactions to that? From maybe Sandeep will go with you first and then Saket.
I think you put it quite nicely, Varki, but again, that goes beyond just city. I think you're talking about larger, much systemic issues. But I think in today's world, what is important, the confidence will come from connections. And we now have other ways of connecting, not just physical, but digital connections. So if you look at today's older adults, older immigrants here in Canada, they are transnational in nature. They have folks from all across the world to whom they are connected. But yes, I mean, what you're talking about, the scam and unscrupulous things that happen, it does still happen. But I think older adults are actually much more digitally savvy, in my humble opinion, than even other folks. So yeah, But again, I think we're moving beyond cities now. We're talking about
right. Yeah. Saket, any insights about that aspect of it?
No, the legal and increasingly the financial, as we are becoming more digital, has become a big factor for safety of senior citizens in our cities. Right? But as Sandeep said, yes, these are larger structural issues which go much beyond.
Yeah,
Add to that.
Sure, Sandeep.
Because you mentioned safety, I think the issue of safety is much more, not so much external factors, but actually internal factors. And I'm actually leading to elder abuse. Elder abuse has become very, very common, and it's growing quite a bit in Canada as the population is aging. And it is much more severe among the immigration population here in Canada. So if you look at the stats, about 1/3 of senior victims, who reported violence against them, were actually by their own family members, by the child, spouse, siblings, other family members, and so on. And the rate of family violence is much, much, much higher among senior females. So I think we need to keep that into account, that it's just not folks from outside, but actually the lot of pressure and unsafe environment internal to where they live and where they house themselves.
Great, thanks. So one of the things I want to make clear to our audience is that we have limited time, so we are scratching the surface, but I hope we scratch the surface enough that we can reveal some of the real complicated issues that underlie some of what may seem like a simple position, right? Saket, do you want to talk to us about transportation and infrastructure and how we plan, design, construct, and provide these transportation infrastructure systems actually could help support the older population?
Yeah, thanks, Varti. Transportation, I think, is, in my opinion, the single most determinant which contributes to independence, empowerment, productivity, and social engagement of the elderly. Right? And lack of it directly leads to isolation and inactivity and exclusion. So I think this is, from a city's perspective, this is the single most important instrument that can play a major role. I would kind of just use a different term like mobility compared to transportation, because transportation is an act of moving someone or something, whereas mobility is kind of more enabling, more empowering, and the ability to move or be moved. Right? So from that perspective, I think mobility may be a better term for this discussion. And of course, again, like with other things, safety, comfort, reliability, and affordability are the key determinants for not only for the elderly, but for most of the people in the city. And this applies to the elderly population. In terms of components that affect mobility, right, without going into too much details, how we design our streets, the sidewalks, the provision of street furniture, resting places, texture of the sidewalks, road crossings, and how much the walking light is on for the duration of it. Two things like transit design, which are typically designed for a mythical, average male of the city, where all the public transit is designed. How do we kind of break that and make it more inclusive? And that is not only about design, but also about a destination. Where do the transits connect to, rather than just connecting to the converging in the CBD? Can the transit also connect to other places that are of interest to the elderly? Right? And the transit infrastructure, the buses and the trains, how many steps, how high the steps are. Buses being low floor height, buses with extra width and things like that. So there are a lot of things, nuanced things in the transit also include sensitizing the operators that when the elderly is boarding the bus, the stopping and the accelerating and waiting and things like that. So it's a very nuanced but a complex way to design transit, which allows everybody to kind of use it more effectively. Right? And this is all more technical, but I think an important part that we sometimes overlook is also the community support. So it's not only the physical infrastructure of mobility or transit, but how others are sensitized in the community to support and to respect when a elderly person is using the transit, right? In terms of priority, respect, giving seats, and so on, taking care of them. Other infrastructure includes like buildings and public spaces, and again the issues of safety and accessibility, other things come in. And of course, there are many other infrastructure things in the city, like the electric grid or the economic infrastructure, or the communication and the digital infrastructure that is legible and not very complex and simple, right? And the civic infrastructure. There are many other things which makes a lot of difference. I'll stop here.
Great, yeah, thanks. So essentially, so you talked about mobility, but we could also talk about accessibility. We talk about that as urban planners, right? It's being able to access the different things that you want. May not be necessarily by moving, right? But you are able to get to it. However, the point I think you're making is that for the elderly, it may not just be accessibility. It's not enough to sit at home and access things. The actual ability to move outside one's home, right? That I think is an important part of a sense of independence. Things like that. Sandeep, any responses to what Saket has just said?
Yeah, the only other thing that I would add to it is about understanding the travel behaviors of older adults, elderly people. Their needs, where they go, may be very different from other folks. Most likely, they're not going to a place of employment, but they may be going to other places. So just very quickly, I was involved in a study here in Toronto area when I lived here. So we had, the place called Brampton, which is just outside of Toronto, and a lot of immigrants who have come and reside in that city. And so we did a small study to see where exactly these older immigrants move around, where do they go? And what we found was that most of these folks, they actually, as their kids have left, their grandkids are at home, if they are much younger, then these older immigrants will take them to a nearest childcare place. And from there, they were walking about 2 kilometers further up to a place of worship, a gurdwara or a temple or what have you. They will stay there because that's the place where they all come together. It's a place for, socialize and things of that in nature. Then they would walk 2.5 kilometers back to their childcare, pick up the kid, and then walk to their home. But there was no public transit. So we pushed the city of Brampton to actually do a pilot study of their own based on our study and do a pilot run of a bus, which they did. And it became very successful. The issue there was, what's the cost and benefit? And they figured out, well, that city, the benefit to these folks, these older immigrants, plus city was making money because, hey, there was enough ridership in that route. So I think those are the kinds of things that need to happen more often to understand that, hey, it's possible that, how they move, where they move, type of mobility, and all of that may be very different from the, let's say, rest of the population.
I would just add to that,
sure, Saket.
Many of these things are not necessarily very complex or expensive either. So my mom has stopped going to malls because there are not enough seats there to kind of take rest. Right? Many people would not go out because there's lack of clean public toilet, right? And that kind of reduces the time that somebody is actually out of the house. Right. So many of these things are really simple things, which is more about actually understanding the barriers of why people move or don't move, and small things that anyway should happen for everybody. Right. So I think it's also a big deal about just sensitizing people and saying, okay, these are low cost, no cost things that can make a big difference.
That's a great point. Thanks, Saket. So now, Sandeep, you've done a lot of work, as you referred to it, about looking at immigrant enclaves throughout Canada and issues around them. So why don't you talk us through housing, which is obviously the central, the key factor in our existence, right? Shelter is key. So housing, and they talk about housing that enables aging in place. So maybe you can explain what aging in place means, and then any thoughts you have about how housing can provide more support for the older persons.
So housing is one of the key factors we found in terms of social inclusion and other forms of inclusion of older adults here in Canada. And we talk about age-friendly communities where the services, structures, and housing are such that they're designed to ensure that the aging in place take place. Well, you mentioned about enclaves in Canada. I would argue in our studies, we have argued that enclaves provide space where aging in place can take place, because we have seen that in such neighborhoods, multiple generations of immigrants live together. There's enough amenities, infrastructure, friends, acquaintances, ethnic amenities of different sorts are all in the same place. So there are a lot of benefits of such neighborhoods, ethnic neighborhoods, especially for older adults and women and children. Now there is a threshold, and we can go into details of that, but there is a threshold of how many ethnics we are talking about, because it is possible that there will be so many of these ethnics living in an ethnic neighborhood that they're isolating themselves from the rest of the society, which is again not good for anybody, including older adults. So I'll just stop at that, just looking at the time.
The last point, Sandeep, is really important, because when we talked about continuing engagement, reaching out, right, this excessive clustering of like people could act against that continuing engagement, right? So Saket, any from India, from your point of view, any comments about housing and aging in place, the challenges that it poses?
Historically, aging in place was happening a lot over last decade or so. Things are changing very fast. And so I think it becomes even more important in the Indian context to have more integrated living option, more by design rather than by default, which was an option about a decade ago, right? And so how can we make our housing more inclusive rather than having the older adults move to senior only housing, which seems to be becoming a fad of some sort. I don't really know the reason. Second thing is, again, I'm looking at really low cost, no cost options. It's the option to accommodate changing needs of the senior adults in the housing. And so if I want to get my apartment kind of elderly ready, it's very little I can get as an off-the-shelf service that I call somebody to say, okay, make the staircase more accessible, or the toilet with all the safety features, or just making the balcony safer, right? And therefore there's a big market and a big scope for these small changes that can be done to existing units as a retrofit measure, but which can be done in a more intelligent, more scientific manner, and which is also reliable and again dependable, right? Borrowing from your example of St. Louis, that there's always a chance that people feel that they don't know what they're getting into. So making this provision also kind of greatly helps in aging in place, which may delay people moving out to more isolated location. Second thing I would want to add to that is from the climate resilience perspective, and heat waves have been kind of hitting us across continents, right? Canada, US, France, India is no exception. And so how can we, in the housing itself, how can we make sure that the units remain thermally comfortable especially when the grid itself is under so much pressure, right? Because the elderly would be the first one to face the burn.
That's a great point, Saket, and I hope everybody captures that. So climate change is actually going to impact the elderly within their housing, because as we know, the elderly are particularly susceptible, vulnerable to temperature changes and things like that, right? And so that's a great point. Thank you. Saket, you want to talk briefly about community health? Because we're maybe running out of time, but we're worried about this. Community health?
So very, very quickly, in the interest of time, I think the aim of community health should be kind of, again, wide, banking on what Sandeep said, that we always need to kind of look at a broader picture. So it's not only about promoting, maintaining, or restoring health, but it's also about emotional and mental well-being. And I think, especially in the elderly community, that is extremely important. Though a lot of infrastructure is often focused on the physical health, the mental health, which is very much neglected, and it goes undiagnosed also. So in community health, I think we should flag that part. And of course, emergency services, access to emergency services, and COVID was a kind of a big eye-opener, right? That how do we get emergency services for the elderly particularly. So again, all of this ties to transportation, housing, and location, accessibility, affordability. And there's a lot of scope for innovation in this domain to not go to get the health services, but how can some of these services reach you, right? And with all digitalization of health, that is another big opportunity. We'll stop there.
Yeah, so we had a previous session, my brother Chaco led that talked about the digitalization and its impact. Sandeep, anything to follow up on Saket?
Sure, and I will get into some of my work on human rights and make that connection as well, if that's okay, Varki.
Sure.
So picking up on Saket's point about equitable access to transportation, to housing, health programs, and clinics, and so on and so forth. And that's where human rights law come into picture, where I sit, especially. So I'll make just a few points. One is that one of the serious issues in the Indian context is that ageism and older adults being discriminated to have access to all of these facilities, infrastructure that we talked about, that it's missing from the Indian Constitution. So essentially, ageism as a discriminatory factor is missing. And Universal Declaration of Human Rights is silent on discrimination by age as well. But I just wanted to say a little bit, but in practice in India, if you see, there are some programs, for instance, in trains, older adults get, reduced tickets of lesser value or what have you. There may be some other welfare schemes to protect older adults. But I wanted to just say about Canada, because some of the work that we did had a direct impact. So Canada's constitution does guarantee equality and prohibits discrimination based on age. It's in the section 15. But there are multiple levels of how human rights function and employed. In the Canadian system, so you have the constitution, then you have at the provincial level, there are human rights acts. So where I live in Alberta, age was not a discriminatory factor. And there was lots of issues around housing. There were housing which were only, like adults only residential buildings. There were age restrictions on condominiums and cooperative housing and so on and so forth. And as of 2017, because of some of our work, it became illegal. So you could just see how much of law has to do with this. Back to the Constitution, there were a number of cases in early 90s which have an effect on what has happened in Canada. In Canada, since 2005, there is no mandatory retirement. So you can continue. So I think these are some of the good things and progress that have been made in the Canadian context because of how the law was changed and how the guarantees are now instituted as part of the Constitution and various provincial human rights acts.
Great. Look, I'm sorry we've run out of time, it seems. My apologies. One key idea to leave you with: cities are not everything. We still have a significant population that lives in rural areas and for whom this would actually be a greater challenge than in cities. So that's something to keep in mind, and particularly in the context of India, right? Thank you both for joining me in this. We will probably continue chatting about this in the future. I think, sorry, one last point. I think we need a system of auditing cities. We need to be able to go in and look at cities and say, these are the criteria we will look at cities and how is the city functioning in terms of its ability to support older people. I promise that's my last point, and we'll stop with that. Thank you. Thank you everybody for listening to us.
Thank you.
Thank you.
Thank you, Dr. Vaki Palatacheral, Dr. Sandeep Agarwal, and Dr. Saket Saraf for the interesting insight and discussion. Ayurveda is a system of medicine which is based on the idea of balance in bodily systems and uses diet, herbal treatment, and yogic breathing. Bringing a better understanding of this is Dr. Jobin Joy Marukuri. Dr. Jobin Joy Marukuri is the 8th generation of a family practicing Ayurveda. He is the Ayurveda physician and medical director of Marukuri Ayurveda both in Kerala and in Germany. He is the founder of Marukuri Ayurveda in Germany. They have 2 centers there. He completed his university studies from Udupi and Bangalore. He further continued his studies under many Ayurveda scholars, Marma specialists, chiropractors in and outside India. He has conducted several international seminars and awareness programs on Ayurveda since 2006 in Europe and the United States. He has also worked as a visiting Ayurveda faculty at ESB Physio School, Germany. Without much ado, I present to you Dr. Jobin Joy Marukuri.
Thank you, Sarah. Thank you, team ILAGA, Dr. Sally Chako, and team for including Ayurveda, the Indian system of healing, as a part of this concept, aging gracefully. It's really an honor for me to be a part of this event. Let me come to my topic. As Richard Schultz said, natural healing is about taking control of your life and being responsible for everything that goes in and out of your body, mind, and spirit. Ladies and gentlemen, good evening. We present to you Ayurveda, a holistic approach to living well. It's an evidence-based practice towards achieving SDG goals through well-being and education, focusing on self-care, health literacy, self-awareness, and self-management. With the kind of lifestyle we lead, modern metabolic diseases are on the rise, and the demand of healthcare and innovative solutions are growing globally. With this in mind, we have two options to either choose lifelong medications or lifestyle modifications. Ayurveda offers a chance for a good health in a holistic way. It's a 5,000-year-old medical wisdom, still an active science or art of living, originated from India, that supports the physical, emotional, mental, social, and spiritual well-being of a person. This definition goes hand in hand with the definition of health according to WHO. The primary aim of Ayurveda is prevention. This includes methods to balance the biorhythm of the body in relation to nature. It's a well-known fact that healing starts from our kitchen. People believe that good food brings good health. Actually, it is the right kind of food which brings good health. Ayurveda helps one to understand what the right food for individuals are through healthy eating habits to prevent diseases. It also emphasizes the need to fine-tune the body, mind, and spirit together through yoga, which is a form of exercise. This is another important tool in Ayurveda to prevent diseases. One must understand that diseases are not formed in a day and are not always visible to us. Ayurveda explains wrong dietary habits as one of the main causes for diseases, which includes eating wrong combinations of food, like cold and warm food together, cooked and raw food together, different animal proteins together in one meal, milk with salty, sour, and spicy meals, etc. Eating food at wrong timings, example, cold food for breakfast, as breakfast time is cold dominant in nature and body, heavy and cold meals for dinner, etc. Eating when one is under stress, eating before the previous meal is digested, eating unhealthy food, eating genetically modified food, eating fast food, etc. Ayurveda explains wrong lifestyles also as a cause for diseases, which includes irregular sleep rhythm, irregular meal timings, excessive or lack of exercise, stress, etc. This awareness helps people to join in preventing the diseases. With wrong dietary habits and wrong lifestyle, metabolic toxins accumulates in the body. Ayurveda has methods to eliminate these accumulated metabolic toxins by detoxification methods like Panchakarma therapies or 5 detoxification therapies, which includes therapeutic emesis, nasal cleansing, medicated enema, medicated purgation to rejuvenate and improve the quality of life. I'm introducing some of the treatments here. First is Abhyanga, a signature Ayurveda therapy. Synchronized massage with medicated oil over 107 special vital points in the body, which harmonizes body, mind, and spirit. Shirodhara, a medicated oil dripping therapy over the forehead, a healing method for psychosomatic diseases or a tool to balance body, mind, and spirit. Nasya, nasal cleansing therapy, detoxify and rejuvenate the sense organs, effective therapy in sleep-related diseases, neurological diseases, psychosomatic conditions, etc. Shirovasti, holding medicated oil in a cap over the head, a magical healing method for neurological conditions like multiple sclerosis, Parkinson's disease, stroke, etc. These are few among the main treatments, and there are many more healing methods and therapies which are selected according to diseases and requirements. Immunity. Ayurvedic way of living harmonizes body, mind, and spirit to balance the biorhythm between body and nature. For this, we must follow a healthy diet. Ayurveda says a diet comprises not only what you eat, but also what you watch, what you listen to, what you read, the people you have around you. These influences not just your nutrition, but also your metabolism. Lifestyle includes things you put into your body emotionally, spiritually, and physically. Yoga and meditation are an integral part of healthy living as it helps to continue or sustain the benefits achieved with the treatments. In Madhukakuri Ayurveda, we promote the concept of let food be your first medicine and kitchen be your first pharmacy. Green concepts. At Madhukakuri Ayurveda, an 8th-generation traditional Ayurvedic family established in India and Europe, propagating authentic and true spirits of Ayurveda, we not only treat the people, we create for them an experience of the way of living, self-awareness, and responsibility to follow a healthy lifestyle. We at Madhukakuri Ayurveda believe in giving back to nature the way she provides us. Towards this, we have adapted the following green concepts at our center: butterfly garden, an ecosystem garden to attract birds, butterflies, and other pollinators. Organic garden, 100% organic manure is used in our garden. Rainwater harvesting, around 10 lakhs liters of water is harvested per year and reused. Ayurveda plantation, more than 100 varieties of Ayurveda herbs are preserved and utilized for healing treatments and in-house medicine preparations. Solar energy, our goal by 2030 is to be 100% solar powered campus. We are moving towards this goal step by step. Biogas obtained from food and organic waste materials. No to plastic. We use only paper or linen bags instead of plastic bags and bottles. Recycling. We join the recycling community led by women organization to recycle materials. Thus, we believe in giving back to nature the way she provides us. Thus, a healthy concept of living includes self-awareness, realization, responsibility for a healthy life, and healing is achieved. It's time we embrace this holistic approach towards living and aging gracefully. Let's have a glimpse into Madhukakuri Ayurveda traditional healing, an impression on our campus, in-house medicine preparation, yoga and meditation, food, regimen, and therapies, etc. Thank you one and all for joining us, Madukukuri Ayurveda, in this healing journey. Once again, thanking ILAGA team to include Ayurveda, the ancient wisdom of healing, in reaching the goal of graceful aging. Thank you very much.
This brings us to the end of day 2 of the YILAGA International Conference.
We look forward to having you all with us tomorrow at 8 p.m. time. Till then, take care, be safe.